Hello, hi, welcome back to our next section in cardiac anatomy. In this section, we'll be discussing the conductive system and the fibrous skeleton. Our supervisors for this section are Mr. Sonal Ori, our clinical lead and lead for education, and Mr. Steve Livesey, our lead mitral surgeon and other cardiac surgery consultant, as well as Mr. Ayman Al-Asar, our senior registrar. Conduction system, starting with the sinoatrial node, sending conductive tissue to the left side via the Bachmann tract, as you can see here, and sending conductive tissue to the AV node via internodal tracts. Then the bundle of His originates from the AV node and divides into right and left bundles. The left bundle then is further discriminated into the anterior and posterior fascicles. Hence, in ECGs, you have bifascicular block and trifascicular block, depending on how many bundles or fascicles are affected. I will not further go into the conductive system anatomy because we will discuss that in more details in arrhythmia surgery. Next is the position of the sinoatrial node and AV node. As you can see, the sinoatrial node is positioned at the junction between the SVC and the right atrium. However, the AV node, you need to open the atrium in order to see it. So the AV node embryologically develops from the sinus venosus as a derivative of the sinus venosus. Hence, it's embryologically, anatomically is positioned in the right atrium. I know it is related to all three valves, the aortic, mitral, and tricuspid, yet it is actually positioned anatomically. It is in the right atrium, and the bundle of His, on the other hand, is the one related to aortic valve or the mitral valve. Now, the tricuspid valve is bounded by an imaginary structure referred to as the triangle of Koch, the boundaries of which are the tendon of Todaro, which is an extension of the IVC edge of the entry point of the IVC to the right atrium. There is an extension of the valve in there, coronary sinus, as well as the attachment of the septal leaflet. The AV node is positioned at the center of this triangle of Koch. Then the bundle of His travels apically upwards, and we will understand why, moving upwards towards the apex shortly now. This is the position of the AV node and the SA node. We understood previous section the blood supply of both of which. Next is the fibrous skeleton. So in order to understand the correct anatomy or architecture of the heart valves, you need to first understand the architecture of the heart. Starting by the transverse section, looking at it from the top view, historically speaking, it was thought that the fibrous skeleton is formed of a disc of fibrous tissue, muscles originating on the top of it, which is the atria, right and left, and then muscles originating below it, that is the ventricles, right and left, and separated in between by muscular and membranous septum on top of each other. However, the fibrous skeleton is more complex than this. Further histological examination deemed this inaccurate, and it showed that there are more details to understand about the fibrous skeleton. To start with, the fibrous skeleton is basically formed of two main condensations, that is the medial and lateral fibrous bodies, designated here by the X marks. These two bodies then send fibrous tissue around 3 out of the 4 valves to a variable distance. It's variable from one individual to the other. The 4th valve sprouting separately from a muscular structure, that is the pulmonary valve. The other 3 valves are all incarcerated in this fibrous skeleton or fibrous tissues. In order to understand this furthermore, you need to have a look at the sagittal section, once at the left and once at the right. Looking at the sagittal section from the left side, you will see how the aortic and mitral valve are in continuity. So there is actually fibrous tissue is continuous between the anterior mitral leaflet and the aortic valve, non-coronary and left coronary cusp. How is that important? You need to understand how you can see here how the jet of blood from the mitral valve is very close to the jet of blood from the aortic valve. If the coaptation margin is a bit further anterior, which is not normal, it is actually positioned posteriorly. If the coaptation margin is close and anterior, it becomes at the far range of the LVOT jet, and this creates a pulling effect or a Venturi effect, if that's what we call it, and disrupts the coaptation margin. It opens the coaptation margin and creates mitral regurg. That's what we refer to as systolic anterior motion, pulling the anterior leaflet to the front, disrupting the coaptation margin during systole, and this happens if the coaptation margin is closer anterior. This, on the other hand, looking at the right side, is not true in the pulmonary valve. As you can see, the pulmonary valve is completely separate from the tricuspid. It originates from a muscular structure referred to as the infundibulum, which is a group of trabeculations of specific orientation, septomarginal, parietal, and modulator band, and it is separate from the tricuspid valve. Hence, the jet of blood is not subject to SAM or systolic anterior motion. The other point of importance here is how this underscores how the pulmonary valve is significant and very suitable for Ross procedure. You can actually excise the pulmonary valve from its muscular bed without disrupting the fibrous skeleton. It is very suitable for the Ross procedure. Next is a special view of the aortic valve. So consider the aortic valve as a tube, and you are looking at it from the front. We will cut the tube, and then laying it open, you're looking now at the aorta from the inside. Mitral valve will be below, aortic valve will be in front of you. Three important structures needs to be signified in here and denoted. One is first of all, the the fibrous bodies, as you can see, designated by the cross marks, then the aortomitral continuity and the septum, whether muscular or membranous septum. It's important here to understand how the mitral valve is very close in proximity to the aortic valve. Hence, during replacement, you need to be very careful not to pick up one of the valve or the other while doing the other valve. So you might induce aortic regurg while doing mitral, or the other way around. Also, it's important here to note how the three structures are in continuity, how they are on top of each other. But if you refold the tube back again, they will become in series. So they are one on top of each other if you're laying it open, and once you bring them back together, they will be in series. So when we discuss annular relations in aortic valve, this explains how they are one after the other rather than on top of each other. Also, it is of importance to note how the medial fibrous body and the membranous septum constitute what we refer to as the central fibrous body, which is the highest condensation of fibrous tissue in the fibrous skeleton. We'll come back to this section again and again in our examinations of the heart, and we will be discussing it further. Finally, last but not least, the third section, that is the coronal section. Looking at the coronal section of the heart, in an ideal world, you would like to think that the heart is divided equally into 4 quarters. However, this is not true. Intrauterine, the lungs are not functional. There are shortcuts to prevent blood from going to the lungs. It keeps them going back and forth, including the PFO, the patent foramen ovale, and the PDA, the ductus arteriosus. And these shortcuts are only because the lung is not functional. The baby is not breathing. After birth, changes happen or are centralized around the fact that the lungs start working. One of the changes which happen is the amount of cardiac output. So initially, the chambers which are in close relation to the lungs, that is the left atrium receiving blood from the lung and the right ventricle ejecting blood to the lung, have less volume because the lung is not functional. After birth, with the closure of the PFO, the PDAs, like the ductus arteriosus is shut, the cardiac output starts just to equalize right and left. But however, the sculpting of the internal architecture of the heart has already been done. This explains why the right atrium and the left ventricle are slightly bigger. They have a bigger volume. After birth, the cardiac output right and left is equal, except with a very small difference, that is the bronchial circulation, which acts as a shortcut on the left side, so increasing the cardiac output of the left side slightly higher than the right side. So as we going back to our point, so the left ventricle and the right atrium are bigger. How is this affecting us? Important point is, one, it identifies how come we can find a congenital defect referred to as the Djibouti defect, that is a VSD between the right atrium and the left ventricle. This is how there is a connection between both of them. They are not equally divided. There is a connection between the right atrium and the left ventricle. More important, this point of membranous septum, which is between the right atrium and left ventricle, acts as a window, allowing the bundle of his to travel from the right atrium downwards towards the ventricles. And if this defect is a bit bigger, it creates what we call the Djibouti defect. I will not go into that in the details because there is a debate about it, whether there is a congenitally actually Djibouti defect or not. Some anatomists and embryologists believe there is nothing. It's just a dilatation of the defect or bigger defect. That's all. It's not a true VSD or anything like that. Also an important point here, how the MRI During looking at an MRI to identify the cardiac morphology, identifies the right side from the left side by this point. The tricuspid valve is always attached at a lower point than the mitral valve. In congenitally malformed heart, performing an MRI, you can identify where is right, where is left. Finally, looking at these relations and fibrous architecture explains to you how come the AV node and bundle of his and the conductive tissue is related to all three valves, because it's positioned at this particular point in the fibrous skeleton, in the transverse section. This explains to you the importance of understanding the fibrous skeleton when we come to understanding the annular relations. This explains how the AV node and bundle of his are related to all three structures. Remember, the AV node is actually positioned in the right atrium, so it is in the central part of the triangle of Koch. The bundle of his, however, travels upwards to gain access to the membranous septum and going back down to the ventricles. Also, understanding these sections explains, as we said earlier, so if you refold the aorta, it will explain how these three structures are in series rather than one on top of each other. Also, putting it back together will explain to you where is fibrous, where is muscular. In some situations, you need to cut fibrous tissue, such as performing annular dilatations, neck procedure or Manugian procedure. Sometimes you need to cut muscle, such as in surgeries for Hookham, a Monroe procedure, or LVOT obstruction relieving, subvalvular obstruction. So you need to understand where is muscle and where is fibrous tissue. We will discuss that when we come to aortic valve. This concludes this section about fibrous skeleton. I hope you enjoyed it. So this is an MCQ just to test your knowledge. I'll leave you with that and see you back again in the next section. Thank you very much.